So Jane, just tell me when you'd like me to start again.
You can start. You can go to the next slide.
Okay, so I'd covered the selection criteria. Apologies, we got knocked out by a connectivity problem. Increasingly, as I've pointed out, we are moving towards health technology assessment methodologies, and especially where we have a new medicine being added, we are beginning to use what's called an evidence to decision framework, an ETD, to really be explicit about the basis for the decision that we make. So the E, the evidence, is what we get from the literature, randomized clinical trials, systematic reviews, and meta-analyses. And we really want to focus on how confident we are on the evidence of benefit, and also whether benefits outweigh the harms. We also bring in those other value judgments, so the feasibility, the values, preferences, and acceptability, and in particular, whether the decision we are making is likely to advance or argue against equity and human rights. And then lastly, the resource uses. How large are the resource requirements, both in terms of the direct price of that new medicine or technology, as well as other additional resources such as laboratory monitoring. So I'm going to now hand over back to Jane to take us into the speakers who are going to focus on a number of the key updates in this new version of the STGs. So Jane, I'll stop sharing at this stage and hand back to you to introduce our next speaker. Thank you.
Thank you so much, Andy. I'm just going to quickly
Thank you so much, Andy.
I'd like to introduce our next speaker, Professor Gina, who's a pediatric pulmonologist and has been involved with the Essential Drugs Program since the late 90s. He's served on numerous pediatric expert review committees as well as NEMLAC, and his expertise lie in critical care, pulmonology, infectious diseases, and allergies. So please welcome Professor Gina.
Thank you, Jane, for those kind words of introduction. My task is to show you that babies and adults are different, and that we cannot just use adult data to actually, if you think back in the history of medicine, to be stronger and to be more resilient. However, and then from there, children, the medication, little adults, and therefore we need to just make sure that we find the data that supports the use of medication in children. So children, there's often a lack of data cause for the adult. Now, if we really think about it, right now, the EMA or the FDA are extending timelines for periods of drugs based on the fact that they have studies in children. Benefits get off prescription for children. When I started in this, there's almost 28% were not extrapolated. We need to be deliberate about the disease pathophysiology, the natural histories, the severity. We also look so that metabolism point RCT case things like systematic, and although you might think that to an RCT, this is not all together and give the space back about slide, please. Next. No, I did wait to be first.
Apologies, sorry, Gina, we're struggling to hear you. The audio on that side is not so great. I think it's coming and going. I'm wondering if we can maybe just move to one of the other presenters, and we'll sort your slides out in the meantime. Would that be okay?
That's fine. That's fine.
Okay, great. Thanks. Sorry about the sound and the technical issues today. So I think let's move on to the next presentation. The next presentation, we're going to be looking at the use of Cotrimoxazole in HIV-exposed infants and the changes we've made around here. I'd like to welcome Professor Archery, who is a pediatric infectious disease specialist in the Department of Pediatric and Child Health at the University of KwaZulu-Natal, as well as working at King Edward Hospital. He's involved in a wide range of research, and we really value his input here. Thank you so much, Dr. Archery. I'm going to hand over to you.
Thanks, Jane. So hopefully we'll have a better time with the yeah, okay, great. So hopefully technology works with us. So thank you for the invite. And I think thanks for those who have joined the call. Again, what we're trying to do is really around understand the decision around Cotrimoxazole prophylaxis for HIV-exposed infants. And as many of you have know that this has been a cornerstone of our treatment or preventive strategy for treatment of HIV-exposed infants. And so just to give you some context, the previous recommendation in terms of previous SDLs and national guidance and the WHO guidelines was that Cotrimoxazole prophylaxis was recommended for all HIV-exposed and HIV-infected infants, especially in that first year. And it's just important to understand the context in which that happened. And that really was in the context of no or very poor coverage of maternal antiretroviral treatment, very little HIV postnatal prophylaxis regimens, and a difference in terms of how we tested for HIV. And in this context, Cotrimoxazole prophylaxis really did show benefit for in preventing the development of pneumocystis jirovecii pneumonia in children who are HIV exposed and then became HIV infected. And that occurred even before children became symptomatic. And often what we would find is that those children would present to a facility or to the ICU with PJP pneumonia as their presenting complaint. And this has changed quite extensively. So again, in the current setting, majority of our mothers living with HIV are on antiretroviral treatment. We are conducting, birth HIV testing and other subsequent testing. So we're making the diagnosis of HIV much earlier. And we're starting infant postnatal prophylaxis for those infants to prevent HIV transmission, and with the proviso of starting antiretroviral treatment in those children. So in that context, the number of children who actually would benefit from this prophylactic regimen diminished quite considerably. So there were two studies that really informed this decision and this recommendation. So the first study by Lockman et al. Was from Botswana, and essentially what they found was that prophylactic cotrimoxazole did not improve the 8-month survival of HEUs, which is HIV-exposed uninfected children, and the mortality rate was pretty much the same. So there was no significant difference between the mortality rate in the cotrimoxazole group of 2.4% and 2.6% in the placebo group. In an additional study done in South Africa and KZN, what they found was that cotrimoxazole was not inferior to daily, so no cotrimoxazole was not inferior to daily cotrimoxazole in breastfed HIV-exposed uninfected infants in these mothers who are accessing PMTC services. And in these, in the study, the cumulative probability of a composite endpoint, and that included, grade 3 or 4 childhood illnesses or mortality, is 0.114 events for the cotrimoxazole group and 0.0795 in the placebo group. So there was a negative correlation in terms of the risk profile. So certainly I think that benefit that we were seeing very early on in the program, where we had many more children who were HIV infected, and our diagnosis of HIV was delayed in the program because of testing and treatment algorithms in the current setting, that was lost. And there's also potential for harm. So in the Botswana study, they found that there was an increased incidence of risk of both cotrimoxazole and amoxicillin resistance, and that's our first-line pneumonia treatment guidelines includes cotrimoxazole for your primary healthcare clinics. And in the study from South Africa, they showed that the cotrimoxazole was associated with microbiome or gut dysbiosis and increase in the resistance genes in these microbiota. And again, just to reiterate, if you look at the back of the envelope kind of numbering and really to reflect on the decrease in the number of children infected. So we've gone down to around 1.7% vertical HIV transmission rates, and with a PJP incidence of 9.5 cases per 100 child years. The number of children that you're required to treat. So so if you look at the figure in red, so you need to treat almost 32,500 high-risk HIV-exposed uninfected infants in order to benefit around 500 HIV-positive infants, which would potentially prevent 55 PJP pneumonias. And that's assuming that those infants would have not received antiretroviral treatment uniformly, which they should have within the program. So we have to potentiate against the potential harm to around 32,500 children in terms of the resistance profiles. So on that basis, the Pediatric STG and the EML, in conjunction with the National ARV guidelines, recommended that cotrimoxazole prophylaxis would only be indicated only once the baby has a positive HIV PCR, and that continues until the criteria was met for discontinuation. And that would continue as per the previous guidelines. So again, just to reiterate, I think the idea was to ensure that the children at the highest risk of PJP pneumonia would benefit from this intervention and prevent children who would not benefit from being exposed to this intervention. And to highlight the priority, which is really around ensuring that mothers remain, firstly, HIV uninfected, but also if they are HIV infected, that we maintain virological suppression in those mothers. And also, if they those infants become HIV positive, we identify them early and start them on antiretroviral treatment, and that would prevent these children from acquiring PJP pneumonia. So thank you. So I'll hand back to Jane.
Thanks. Thank you so much, Professor Archery, for your insights. And just a reminder for everyone to post any questions you have in the Q&A box. I'm going to now welcome Dr. Tanya Ruda, who's a pediatrician in the Division of Community Pediatrics at the University of Witwatersrand. She's been involved in the pediatric STGs and EML for various roles since 2017. She's also now co-opted onto the Primary Healthcare Expert Review Committee, providing input with a child lens. She also currently serves as the Secretariat of the, as a Secretary of the South African Pediatric Association. Thank you, Tanya. I'm going to hand over.
Perfect. Thanks, Jane. I'm just going to share quickly. And then, let's see. All right. So thank you very much, Jane, and a good opportunity. We're happy to be doing this. I'm just going to quickly speak about two components of the changes that we've made. One relates to IV fluid therapy in the book, the STG, the pediatric hospital level, and the second one relates to zinc. So firstly, when we're speaking about fluid changes that have been made, resuscitation fluids used to historically always only be recommended when we were doing a resuscitation on children to use normal saline, so sodium chloride 0.9%. And for reasons that I'll explain in a minute, modified Ringer's lactate has been added as an alternative to sodium chloride. So there was a randomized controlled trial that was published that compared the use of Ringer's lactate and normal saline in the setting of acute severe diarrheal illness in children, and so using the WHO classifications of severe dehydration. And these children essentially were randomized either to receive Ringer's lactate or normal saline in their rehydration phase of their illness for up to 6 hours. And they measured the endpoints biochemically as well as clinically, and essentially found no difference in those who were receiving normal saline or Ringer's lactate. So based on this study, we've actually made the decision to change our current recommendation to add an additional alternative of Ringer's lactate to that normal saline for the various indications that require IV fluid resuscitation. So in addition to comparable efficacy, you can see over there that it says that the costs are actually equivalent. So Andy was mentioning earlier in the first presentation that cost is always a big consideration when you're procuring at a national level. And so the per liter price is quite similar, as you'll see over there. But what's quite interesting is that the volumes procured currently of Ringer's lactate are much lower than that for normal saline. And so if we were to start prescribing more Ringer's lactate, it might trigger a potential cost reduction in the next round of procurement of that fluid. So that's one change that has been made. The second one is related to IV maintenance fluid therapy. So I think many pediatricians or many child health practitioners will be very familiar with half-Darrow's dextrose. And what's quite interesting to note is that that fluid has been removed completely from the pediatric hospital level STG. And the current recommendation is now to use 5% dextrose saline as maintenance fluid when it is necessary. So to understand the reasoning behind this, I've just brought up this table that shows us, just referencing here a balanced solution. So you can see over here that these values in the balanced solution are really what most closely approximate plasma. And that's actually what we're trying to mimic when we're replacing fluid on a maintenance, for fluid maintenance in a child. What we were using previously, over there you can see the half-Darrow's dextrose, and you can see particularly in relation to that sodium, but all of these chemistry markers are well out of keeping with what's seen in serum. It's a hypotonic solution, and the tonicity is really the key factor in terms of the decision making. The current recommendation is now to use 5% dextrosaline, as I've said, which over here appears hypotonic, but that's because of the additional 5% dextrose, which metabolizes really quickly, and then it becomes essentially an isotonic solution, as you can see over there, just the normal saline. I've included the pediatric maintenance solution, which is a very bizarrely named fluid. I know that it's still available in some hospitals, and I have still seen it used, but the naming of this fluid is really something that should be, well, it's just the opposite of exactly what it should be, because you can see here, even more than the half DD, it's even more hypotonic and really potentially dangerous. So it really just has no place in pediatric practice. So our current recommendation, or the new recommendation, is to use a 5% dextrose saline solution for all children. And the basis for that is because of the potential adverse effect of iatrogenic hyponatremia. So there's a lot of data and a lot of evidence that speaks to this point specifically. So I'm just showing the systematic review that informed the European guidelines, the clinical practice guidelines, that reference over there. And what they have done is produced quite a nice infographic in this article. And the point specifically that we're speaking to here is their second PICO. So you can see that they addressed a number of issues related to IV maintenance fluid therapy, but specifically related to tonicity. The question, do isotonic fluids versus hypotonic solutions as IV maintenance fluid therapy impact on clinical outcomes? And the answer there is a resounding yes. So in this meta-analysis that they've done, there were 17 randomized controlled trials that were included with about 3,300 children, and it showed an odds ratio of 0.41%, as an odds ratio of 0.41 reduction in, so a significant reduction in the chance of developing hyponatremia, which would then be iatrogenic, when compared to the use of hypotonic solutions. So again, with the consideration of the costing factor, you can see that the half Darrow's dextrose is only available in 500 ml bags, and the price per liter, if we obviously then use 2, would be 25 Rand. The current recommendation is available in 1 liter bags as well as in 200 ml bags. And what's quite interesting, and people don't often realize that, is the 1 liter bag is significantly less expensive than the 200 ml bag over there. So that cost per liter is quite interesting. And so switching to this new fluid as maintenance therapy when it is required would actually be a significant cost saving. So just a few important points to note related to IV fluid therapy in children. And the main thing is actually that most children can and should receive maintenance fluids orally or through a nasogastric tube rather than getting IV maintenance. When children are receiving IV maintenance therapy, they do need, or IV fluid rehydration or maintenance, it does need to be done with frequent reassessment. And that is firstly because of the potential risks related to fluid overload, but also so that as soon as possible, you can change them to an oral or nasogastric route. When you are rehydrating a child, or the need to rehydrate, the oral and nasogastric route is also preferred to the IV route for the same potential hazards. And also when we are doing rehydration in any form, IV, oral, or nasogastric, a rapid rehydration is preferred to a slow rehydration. Okay, then just moving on very quickly to the zinc amendments that we've made to the booklet. So we know that in the case of acute and chronic diarrheal illnesses, the zinc supplementation is recommended. And that's because of the shortage, that the supplementation shortens the duration of diarrhea, reduces the stool outputs and the number of stools, and reduces the risk of persistent diarrhea as well as potentially for subsequent illness and increased weight gain later on. We also know that zinc is associated with gastric irritation, and it has a metallic taste, and that is dose related. So the previous recommendation was for children under 10 kilograms to receive 10 milligrams per day, and over 10 kilograms to receive 20 milligrams per day for 14 days. But an article published recently in the NEJM did a randomized controlled trial which tested various doses of zinc, so tested 4,500 children, randomized them to three arms, either to receive 5, 10, or 20 milligrams of zinc, and these were the outcomes. So there were outcomes in terms of the diarrheal illness, so the duration as well as the number of stools, and then there was a safety outcome as well. So this is a very complicated slide, but I'm just going to summarize it for you quickly. Essentially, for this first and second outcome related to the duration of diarrhea and the number of diarrheal stools, there was no statistically significant difference from the doses that were received. So whether you're receiving 20 or receiving 5, there was no statistical significance in the difference of the duration of the number of stools or the duration of diarrhea. But when it came to the risk of vomiting within 30 minutes of the dose administered, that actually was a statistically significant finding with a reduction related to the use of a lower dose. And so we have updated the recommendations so that children are no longer required to take 20 milligrams regardless of their weight. So everybody now is recommended to receive 10 milligrams of zinc per day for 14 days when they have diarrheal illness. And that's because there is, it's associated with better safety profile in terms of less vomiting. There's no compromise in efficacy, and there is a decrease in cost. So thanks, Jane. That's it from our side.
Thank you so much, Tanya. That was great insight into two interesting topics. We're going to go back to Prof. Gina now to see if the audio is a little bit better. Let me just share the slides, and then I'm going to hand over to you, Prof. Gina.
Yeah. Hello?
Yes, can hear you. Can you try? Okay, we seem to, Prof. Gina, we seem to be having issues with your audio. I'm going to propose that I maybe talk through the slides, and then for questions, please pose them in the Q&A, and Prof. Gina can answer them as they come up. Would that be okay, Prof. Gina? Okay. So I think we didn't hear much of the presentation, but I'm just going to speak through the slides, and please ask your detailed questions in the Q&A box, and we'll ask our experts to address those as need be. A lot of times in the pediatric STGs and EMLs, we faced with issues where there's not a lot of research that is done in children, and it's really lacking or very limited. The extrapolation of the benefits and risks from adults to children is performed during drug development, and often explicitly used by pediatricians when they are prescribing off-label agents in children. When extrapolation is done, we need to deliberate whether the disease pathology, the natural history, and the disease severity are similar among the pediatric group and the adult group. We need to look at drug-drug interactions. We need to look at the drug metabolism according to the age group, whether it's a neonate, an infant, a child, or adolescent. And we need to look at the evidence that has been done of effectiveness and safety. Often this is not always available in the highest quality, like our randomized controlled trials. So we need to rely on lower levels of data, such as observational studies. So as a starting point, the pediatric group always looks for data in the pediatric setting before considering any kind of extrapolation. This slide just shows you the vast differences in terms of metabolic capacity, the distribution, the GIT function, the renal function, as a child ages. So it's really, really important to consider this when we're extrapolating data, and with any kind of drug decision. Doses are going to change from months to years as we progress and the body develops. So one of the areas that we did add in the new SDGs and EML was a section on massive hemorrhage with massive transfusion of blood. So the adult SDGs and EML included tranexamic acid for massive transfusions to expedite definitive control over this bleeding. However, for children, this needed to be evaluated as there were concerns with the efficacy. What was evaluated was what evidence we found was a systematic review and meta-analysis that looked at the effectiveness and safety of tranexamic acid in pediatric trauma, and it found that the benefits were unclear. Tranexamic acid was not associated with any increased survival in pediatric trauma after it was adjusted for patient-level variables such as injury and severity. The only area where increased survival was found was a subset of patients who experienced trauma in a combat setting. However, this was not applicable to us. Thus, in the pediatric expert review and updated EML, tranexamic acid was not included for massive hemorrhage with massive transfusion. Instead, the treatment recommendations were included below. So for facilities without access to a blood bank, lyophilized plasma is advocated. Those where there are access to a blood bank, a massive transfusion pack is to be requested. And this typically consists of blood cells and lyophilized plasma and platelets. However, all of these patients will need to be referred. And this is the new section in the STGs. Thank you. I'm now going to open up to any questions. So we have had a few questions on fluid within the chat. I think so. I'm gonna ask them to you, Tanya, if you don't mind. So some of the questions were around the removal of DARROs and to just indicate what the replacement is, as well as to just outline what the current recommendation for rehydration fluids should be. Can I hand over to you, Tanya?
Sure, thanks, Jane. And I'm going to ask Gary or anybody else to jump in as well if there are specific additions that they want. So the change for IV maintenance fluid therapy from the usual, and I think many people are familiar with half DARROs dextrose, is now to be using a 5% dextrose saline solution instead. And I see that there was one comment in the chat as well, and that in the Western Cape, from a cost-benefit ratio, that's also far superior. So superior in many ways, particularly related to the risk of hyponatremia, iatrogenic hyponatremia in children. Jane, what was the second part of that question?
So the current recommendations for rehydration.
So rehydration fluid, and it depends obviously on the indication and the degree of dehydration, and that I think goes without saying. So and the study that we cited was related to children who had a severe form of dehydration where IV fluid is usually indicated, and in that instance the trial was done using a normal saline, which is what the current recommendation was in previous books, but also trialing that against modified ringers, and there was essentially found to be no difference. And so either of these fluids is now suggested to be appropriate for this indication. So for the various indications of shock, we've recommended either normal saline or modified ringers lactate. And in the instance where rehydration for severe dehydration is required, rather than only recommending normal saline, it is now recommended that we can also use ringers lactate as an alternative. So either of these fluids is essentially equivalent in efficacy. So no difference in the effect or biochemical markers subsequent to rehydration, or the time frame that it takes to do the rehydration. There was no significant difference in any of those parameters when it was searched for.
Thanks very much, Tanya. Dr. Rubinson, can I ask you, so we throughout the SDGs, we've indicated that obviously preference would go to oral and MGT administration of fluids. What settings would this not be possible, or could we do this in conjunction with the IV route? Would you be able to clarify on that?
Sure, Jane, thanks. Happy to try to do that. So in essence, the vast majority of children would be suitable to receive their rehydration and maintenance fluid via the oral route. If they're not able to ingest the required volumes by themselves, then the second line preference would be for the nasogastric route. And patients where there's excessive vomiting or where there's possibly concerns around a surgical abdomen and potentially a need to go to theatre, and maybe kind of a few other isolated examples would be those patients where you would, until those reasons pass, would consider using intravenous rehydration or intravenous maintenance fluid. But the vast majority of patients would be managed, or it would be recommended for them to be managed with oral nasogastric maintenance fluids. I hope that addresses what you're asking.
Thank you so much. And we've got lots of fluid questions. It seems to be the hot topic of the afternoon. Another question is, if someone is on maintenance IV fluids of dextrosaline, is there any requirement for additional potassium to meet daily requirements for anyone in the panel?
I'm happy to take it. I've got another meeting starting in less than a minute, so let me answer it quite quickly. And then apologies, I'll need to leave. But in essence, yes, I mean, children do have a daily requirement for potassium too. And in many of these patients where you're giving them intravenous fluid, they often are potassium deficient, even without considering their daily requirements. And that's often because they've had got acute or chronic diarrheal disease. But again, most of those patients would be getting could be getting oral potassium either as part of their enteral feeds or as an additional supplement. And if there is a need to add additional potassium, that can be added to the dextrosaline, or if the alternative fluid which would be used would be something like Ringer's lactate that does contain potassium in it too. And there is a question I see here just coming up now around Ringer's not containing glucose. It does contain lactate, and lactate in most patients will be metabolized to glucose, and we certainly find that almost no patients become hypoglycemic while receiving Ringer's as the maintenance fluids. But certainly, if like for anyone else who, for example, isn't receiving enteral feeds, glucose monitoring should be provided. So should be part of their care. And if their sugars are dropping, certainly before it drops below the normal range, it would be appropriate to correct that either by preferably adding enteral or nasogastric fluids, or if that still isn't an option, then by adding glucose to the Ringer's lactate. But again, it's certainly in our experience that seldom seems to be necessary. Thanks.
Thank you so much, Dr. Williamson. I think we have time for one last question. Tanya, I'm going to direct this to you if you don't mind. So is the recommendation for rapid rehydration does it still apply to hyponatremic children or children with renal or cardiac issues?
Thanks, Jane. So I think that we have to consider the clinical context of the child very cautiously. And so no is the simple answer to that question. You'd have to consider what the other needs are related to that child. So in the sense where you're concerned with rapid rehydration of a child with hyponatremic dehydration, perhaps that fluid might not be the best option, the most suitable. So caution in various settings need to obviously be applied when a child is in those situations. And again, we're going to reiterate what Gary has said. If at all it is possible to not use the IV route for rehydration, that is probably the safest way to go about doing rehydration for all children, particularly with those who have got these comorbidities on board as well. So this cannot be routinely applicable. We have to consider alternative the comorbidities that do coexist. But in general, for the majority of patients without all of those significant things, there is good evidence to suggest that rapid rehydration is the way to go. in various formats. IV is probably the last one. If at all possible to avoid, you should.
Thank you so much, Tanya. We've reached the end of our session time. So it's just for me to say thank you so much to our panelists and our presenters for sharing their insights. Thank you to our attendees for joining and sticking with us through technical difficulties. And thanks to the Knowledge Hub for hosting us. This is the first session of 3. The next session will be held next Tuesday, the 5th of September. We'll be delving into pediatric pain, and we will be sharing those links, and the Knowledge Hub will also be sharing those links. We will try to address all the questions that you've presented in the question and answer boxes. Also, please feel free to email the Essential Drugs Program. It's saedp@health.gov.za, saedp.health.gov.za. Thank you everyone for joining, and we look forward to seeing you next Tuesday. Goodbye.
Bye-bye. Thank you. Please complete the survey that was posted. Thank you very much. We'll appreciate that. Thank you. Bye.